noon now in Florida. And this is Dr. Ara Deukmedjian, CEO and founder of Deuk Spine Institute. We are broadcasting live surgery for research and education. Actually for education, not for research. But our patient here has traveled from Chicago to have her back fixed. She's having back pain, leg pain. Her pain is down the right leg. And she didn't want to have any fusion surgeries or open back surgery. She wanted endoscopic spine surgery, minimally invasive spine surgery, and that's what she's here for. Our patients are awake for the beginning of the surgery, and then we put them to sleep once we start doing the actual laser part. So she'll be awake, and I'll be talking to her as well as my staff. Sean, you want to go over the MRI real quick?
Yes, if you all look, we have the patient's MRI report up on the screen. As you can see at the levels we're operating on, it has identified that they have a disc bulge, stenosis, and neuroforaminal stenosis, which means a narrowing of the neuroforamen. That's evidence of nerve root compression that would be causing their nerve symptoms. So we're operating today with the Deuk Laser Disc Repair endoscopic laser surgery to correct the herniations and get the compression off of the nerves.
The other way. Yep. All right. So we're getting ready to get started here. I'm reviewing the MRI one last time in the operating room just to make sure we're doing the right thing. We're doing 3-4, 4-5, 5-1. Right approach. We're on the right side of the patient. Okay, ma'am, we're going to get started. It's Dr. Deuk here, okay? Are you comfortable?
Yep.
Our last patient we just finished, she's in the recovery room crying because she's so happy. Her leg pain is gone. Her back pain is gone. And she's just smitten with emotion. She's a little nauseated, but we'll watch her for a little longer and make sure she's not nauseated before she leaves. Okay, I'm going to get started. I'm going to give you a little bit of numbing medicine, okay? This is different than the neck because for the neck you were asleep from the beginning, but I'm going to put you to sleep, I promise. Dr. Santiago will put you to sleep, but before we do that, we need your help, okay? All right, we're going to get started. Let me know if you're having any pain or discomfort. Just say ouch, and I'll go ahead and give you some more numbing medicine, okay? Don't move off the table though, whatever you do. You're going to feel a little bit of burning. That's just the numbing medicine going in. Are you comfortable?
Yeah.
All right. Now you promised me before that you were going to try to help me keep Dr. Santiago here. Remember?
Yeah.
Okay. Are you still going to help me? 7 cc's? Are you still going to help me with that?
I hope so.
We talked about putting a chain on his leg and a padlock, not letting him go back to South Florida. So, can you grab his legs down there?
Not right now.
All right. Okay, let's get a picture. Dr. Patel always says picture, I say shot. But in the end, we're asking for the same thing. We're asking for an X-ray picture. We use X-rays to find where we need to be in the spine. And shot. Let's go lateral, please. Maybe a little bit too low. Yeah, probably a little bit too low. Let's see some numbing medicine again. Uh-huh. Shot. Let me see. I think we need to start just, I don't know. We need to see 5-1 better. right. Let's see, what are you doing there? So we need a little of this, probably. Bring my side down. Did you do that? All right, and now we need a little bit of wag. I think we're too far south. We need to aim a little further north. Shot. I think that's better. That may be as good as we can get. 5-1 on the MRI. Can I see a different slice on the MRI, please? Can you move the MRI? Go to the middle of the spine. Other way. Stop. All right, that's good. Just leave it there, please. I think we can wag a little bit more. And I think you're too far south with your fluoro, okay? I don't know why we're so far south again. We need to be further north. Shot. All right. We definitely need to do something with this. Try one way and then the other. That may be, yeah, it could be the other way we need to do. I think that's better, right? What do you think, Santiago? Let's try to do a little bit more, maybe, and see what happens. I don't know if that's better or not. Do more. It may be worse. Shot. I'm thinking worse. Let's go the other way. Shot. That's pretty good. That may be actually the best we've had. So for those of you wondering what we're doing, we're starting by getting our x-ray picture, which is going to guide me to do the surgery. We're getting that optimized. What that means is I'm trying to find a position of the x-ray machine relative to the spine. It just still seems off, though. That's the thing. Why don't you release this with me? Shot. 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 That seems to be getting worse. What do you think? Shot. That may be the best we can do right there. Let's just lock that down. It's hard to see at 5-1 because there's a lot of soft tissue, but shot. That may be the best we can do. Are you comfortable? Shot. All right, let me know if you're uncomfortable, and I'll do what I can do to make it better. That's where we are right there. Shot. Let's go AP. And shot, quick AP shot. Yeah, that's what I thought. All right. Shot. Go lateral. Huh? No, I think we're okay. Dr. Santiago has worked his magic again. So our trajectory is not so bad. Shot. I know Dr. Patel has already treated the facets. Shot. 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 I apologize. This is the worst part of the surgery for you. I know. You have to be awake, but I do need your help. Shot. Shot. And L5S1 is the hardest to achieve access to. Shot. Shot. A lot of arthritis here. Shot. 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 Are you awake?
Yeah.
Are you uncomfortable at all?
Just tender and that.
Anything going down the leg?
No.
Nothing. Just in the back, right?
All right. Release the wag. Shot. That's better. Lock it. Let's have some num-num. Skin numbing.
Feeling that, but it's okay.
Where do you feel it?
But it's okay.
Where do you feel it?
Well, when you injected it, it felt like a
Oh, that was in your skin. Yeah. I was just giving you more numbing medicine. That's all.
okay.
Shot. If I can just get around this facet. Shot. 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 You're doing great, by the way. This is definitely going to be the hardest part of your surgery. Shot. Just getting to that L5S1 disc. But once we're there, we're home free. Shot. Your bone spurs keep pushing me the way that I don't want to go. Shot. So I'm not, that's why it's taking a little bit longer. But everything's fine, I promise. Huh?
Get rid of my bone spurs.
Well, we're not going to get rid of all your bone spurs because they're not causing any problems. They're just making it difficult for me to fix your disc by shoving my needle out of the way. Shot? But don't worry. I am not so easily deterred. Shot. Perfect. Are you comfortable? You're doing great, by the way. Shot. Okay. The hardest one down. Shot. That's good. Okay. Well, we got 1 out of 3 access to 1 out of 3 of your discs that we're fixing. So I know it sounds like we haven't done very much, but the one that we did do is the most difficult to gain access to. Raytech. Is there epi in that local? All right. So we have access 5-1. I'm just have you leave things where they are now, but again, we're way too far south. I would move us further up north. See the hip joint? We shouldn't see the top of the acetabulum, okay, when we're imaging the lumbar spine. So that's a dead giveaway you're too far south, okay? Which means you're pulling in a lot of soft tissue that we don't need, which means that the x-ray is going to work harder to give us the imaging we need. Are you pulsing? Okay, just keep that in mind, okay? When you're doing imaging of the spine, you should never see the hip. She stopped all of her anti-inflammatories, right? All right. Shot. Okay, good. Shot. Somehow we shifted a little bit. Shot. Let's see if you can clean that disc up just a little bit. Shot. See how it's just not lined up exactly where I want it? You see that? Let me have another ray. Did you change? Yeah, that's better. Definitely better. Okay, our trajectory looks really good. Are you comfortable still? Shot.
Yeah, just feels like a deep bruise.
Okay, well,
Okay.
a deep bruise I can live with for now. We'll make it better, don't worry.
Do your magic.
We're gonna do our magic, and you're gonna be very happy when you're done.
Get rid of the burning.
Huh?
Get rid of my burning bit.
Shot. 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 All right, let's go. We've got one more to go, and I think your alignment looks fine. We can access all 3 through 1 incision. Hi. So most of the time when we do these lumbar surgeries for back pain, we can get all the discs fixed with just one incision, one cut in the skin. And I think we're going to be able to do that for you as well, okay? So, shot. I've gained access to 2 out of the 3. We have 1 more to go. Shot. Where do you feel that, Shot? Where do you feel that?
In my back.
Okay. Everything's okay now. We're nowhere near the nerve. You're doing good. You're doing good. I promise.
Not my leg.
Huh?
It's not my leg. My back.
Yeah, it's, yeah. Shot. Shot. When I first started doing these procedures, I would do one disc, shot. Then I would wake the patient up and I would then place the needle for the second disc. I know it sounds silly right now, but that's how it was in the beginning. You know, and then I realized that we could do all this part in one fell swoop and not have to wake the patient up again. Shot. Shot. I feel the herniation right there. You see that? Shot. Shot. All right. So you see the tip of the needle, everyone, at the top one. The disc, I should be feeling the disc another centimeter in front of the needle, but right now the tip of the needle is pushing against the herniation.
Is that L3?
Yes, that's the L3-4 right there. You feel that?
Yeah.
So I feel it's bulging out into your foramen right where your nerve is. Shot. So we're gonna go past it into your disc right now. Perfect. Yeah, that's one of your bad discs. I've got some good news and some bad news. The good news is that we've gotten all of our positioning needles in. The bad news is that this is right before you get to go to sleep, so I need your help ensuring that we're in the right place, which means that we're going to be testing these discs. Have you ever watched me test these on the internet? Do you know what happens next? What? Huh? Ooh, smart lady. How bad is that on a scale of 1 to 10?
Oh, that's a 10.
All right, is that where you get your typical pain?
No, I go with my leg.
All right, but you do get back pain too, right?
I do all the time get back pain.
Is that in the area that you get your typical back pain?
Yes, it is.
Of course it is. So you had a 10 out of 10 concordant at 5-1. That was L5S1. So we just confirmed that the disc is causing her back pain. Now she also has scoliosis. She has listhesis, slippage of one bone on the other. But we didn't test any of those. We didn't trigger any of those. And what I'm getting at is those aren't causing her pain. It's the disc that's causing her pain. We only injected the disc. The only thing we would elicit or stimulate pain from was the disc, and it created her pain. Now, when you wake up, you'll forget that I had to do these tests on you, okay? How bad is that on a scale of 1 to 10?
You warned me. That's a
Huh?
10 too.
That's a 10. I can't warn you, because then it wouldn't be, huh?
That was a 20.
A 20 out of 10. That was L45. That's the middle one, L45, was a 20 out of 10, okay?
Oh, that was bad.
I know. And but here's the good news. The reason you flew halfway across the United States was for me to fix the pain that you're having right now, and we're going to do that. When you wake up, your back pain will be gone forever. This pain you're having from your discs will be gone, unless you re-injure them, which you're not going to do, right? All right, that's the 3-4 disc herniation. So it sounds like that's causing pain too for you. Yes?
Yeah.
How bad was that on a scale of 1 to 10?
1 too.
That was a 10?
Yeah.
All right. So you got a 10, a 20, and a 10. Concordant. That was where you typically get pain?
Yeah.
All right. Now guess what? You get to go to sleep, and you're not...
My coccyx or my tailbone on my hip too.
Well, Dr. Patel already fixed that. You're getting like the deluxe car wash here.
You have to check 5 too.
You're getting the waxing, you're getting the wash, you're getting your rims, cleaned. right? The full detail.
Did you check 5?
Yeah, we checked L5S1. You were 10 out of 10.
Oh, yeah.
The worst was the middle, L45, where you have the listhesis. Yep. All right, we can actually see your herniations. They're sticking out like, well, I won't say what they're sticking out like, but it creates an image. Yes, like 2 herniated. You can see the double shadow. 2 herniated discs at 3-4. All right. When you wake up, we'll be done, and your back pain will be gone. All right? All right, she's already asleep. Good. So, for those of you watching, I've gone in transforaminal with these needles. I've accessed her discs that we thought were causing her back pain based on her MRI and based on her physical exam. Remember, MRIs will never tell you where back pain comes from, ever. You have to do a physical exam. Without a physical exam, you will never find a patient's back pain source. So people out there that have back pain and your doctor just orders an MRI and then you find a herniated disc, that doesn't mean the herniated disc is the cause of your back pain. Okay, I promise you. There's other causes that are even more common. Shot. So you have to have the proper physical exam done, and that's where most doctors fail. They don't do a proper exam. They may do a physical exam, but they don't do a proper physical exam. I'm going to have to reprogram Dr. Santiago's GPS so that he thinks he's in South Florida when he comes here. So then he'll just stay here. Okay, so we're advancing the dilator into the herniation, right through the tear. You see the black tear there? And once I get the dilator in, I'm going to be able to put the tubular retractor shot. Shot. So we're inside the L3-4 disc. I passed through the tear that was already there. You could see the tear on the discogram. It leaked the dye out through the tear. So I injected the dye in the center of the disc and it leaked out through the tear. That just shows you how that there's a tear there and how big it is. But the dye I put in was not just to test the disc to see if it was painful. The dye that I put in was also had the purpose of staining the degenerated disc from the herniation blue. So it helps me find the tear and repair the tear. The reason I can find the tear with the blue dye is the blue dye stains and adheres to or bonds to the herniation, whereas the annular tear is white. So you'll see white with blue, a blue streak, and that's the tear, and that's the interposed herniated disc. All right. I'm giving all my secrets away today. You guys see the blue here? You see the blue? Sean?
Yes, we can.
What do you see when you look? You see red, you see white, you see blue. That's a true American right there. Red, white, and blue. Bleeding red, white, and blue. All right, now who put this on here? You can't do that. Only I can put this on here. Because there's a certain way to put it on. You see the black line? Yes. Has to line up with this. All right. Any questions from our audience?
None so far.
Well, in we go down the rabbit hole. There it is. Herniated disc, stained blue, annulus white. The red is blood, red, white, and blue, red, white, and blue. It is not the French flag. It is the American flag. We are in America, folks. Deuk Spine Institute's located in Florida. the best state in the United States. I'm sorry, I have to say it. Every time I travel, no matter where I travel, and I do enjoy traveling, I always miss Florida. I also miss California, where I grew up. But Florida is a wonderful state to live in for lots of reasons. We have beautiful skies most of the year, great weather. We have lots of beaches if you like the ocean. We're located here at Deuk Spine Institute on the east coast of the United States, right where NASA is, Kennedy Space Center, where the space shuttle launches. We've been here since the very beginning of our company in 2004. As a matter of fact, I was a physician on NASA's payroll, and I would attend the launches of the space shuttle when the space shuttle program was still in effect. I was one of the team on the medical team that supported the launches and landings of the space shuttle. There were 3 of us, and it was not always the same 3 doctors. They changed depending on people's availability, but I was on that medical team that support the space shuttle missions for several years. Here, take this. So I had the privilege of being very close to the launching pad. It's 2 miles away. And I was on the tarmac where the space shuttle would land. I was part of it's really a convoy of about 50 vehicles that would support the shuttle's landing. So once the shuttle landed on the giant landing strip here at Kennedy Space Center, the shuttle would land like a jumbo jet landing, and then right after it lands there would be a convoy of about 50 vehicles. And the medical team was in one of those vehicles. We were there for the astronauts to take care of them in case they were not well, and in case there was a problem like the shuttle crashed or something in the swamp. There was a recovery team with literally a swamp vehicle that could go anywhere in the swamp and extract the astronauts. There was one vehicle in particular that I still get a chuckle out of. It had a giant fan built on the top of it, and literally like just a giant fan. You'd think you were looking at one of those really old fans in your living room from like the 1930s, and it was on top of this vehicle that would drive the fan around. And obviously the reason for the fan was that the shuttle itself has propellants and chemicals used in its cooling system that are highly toxic to humans. And so if there's a leak from landing, if any of those cooling systems are compromised, these really toxic chemicals would be leaking out around the shuttle, so the fan was there to blow them away, to blow them directionally away from the astronauts or the people trying to help. So I never saw the fan in use, but I did see it in action driving around with the rest of the convoy. There was also a giant RV for the astronauts to get into after they got out of the shuttle, and to relax, air conditioned. I'm sure it had all the amenities, but it was quite an experience. I took my camera along with me, and I got some good photographs. It's impressive to see the space shuttle with its landing gear out, sitting on the tarmac. Everyone sees it on the launching pad, attached to the solid rocket boosters and the liquid booster, the main booster. But nobody ever sees it on the tarmac, you know. The media likes to get pictures of the launch, but they don't really get much pictures of the landing. Because on the landings, the space shuttle looks like just another airplane. A very special airplane, but just another airplane. So, Anyway, Deuk Spine Institute is located right here in Brevard County, Florida. This is the Space Coast of the United States. This is where currently SpaceX launches their rockets, and obviously the United States space shuttle program has now been privatized, and SpaceX, I think, is the biggest player right now. I know that Jeff Bezos from Amazon built 1 million square feet just down the street from us. A building with 1 million square feet, 2 buildings with 1 million square feet. And those buildings are part of his company called Blue Origin. And they're supposed to be building rocket engines. All right, now take a look. You're watching space age spine surgery. You won't find this surgery anywhere else. It's here in the Space Coast. It's the most advanced spine surgery in the world. This is the annular tear. I'm touching it with a laser. I haven't zapped it yet because I want to show you. It's a little bit overexposed with the light, but we're fine. If you want to turn it down 1 notch, you may be able to see the blue a little better. But there's blue in there, and what that blue is staining is the herniation, and that's stuck inside the white fibers of the annular tear. And that's what this patient's body has been trying to get rid of, is that blue stuff in there. It's been fighting it like a battle that just never ends, you know? And the battle just goes on and on for years, and it creates tremendous pain in the patient's back or neck if it's a herniation in the neck. And the body is trying to heal this tear, but it can't because there's too much of the blue stuff in there. So I'm coming in with a laser and I'm helping her body heal her tear. And the tear is the basic part of all herniation. So everyone's herniated disc that causes pain, it's from this tear. And that's what this surgery fixes. The Deuk Laser Disc Repair is the only surgery in the world that repairs the tear. Now, of course, there are going to be people who do what I do in the future. They're going to try to follow what I do. I'm having trouble getting the fiber to 12 o'clock. It's a little better right there. But they're going to start doing what I do. But this is where it all started, Deuk Spine Institute, here in the Space Coast of Florida. Someday this procedure will be done all over the world because surgeons will realize what I'm telling them is true, and they'll buy the equipment and they'll learn how to do the surgery. But it all began right here. Right where the space program began. Any questions, Sean?
None at this time.
Now, I think I told you all our patient here today that I'm operating on right now is a nurse. She's a nurse in Chicago, Illinois. She's been a nurse for many years. She's a very experienced nurse at the hospital. She was in Chicago and she had problems with her neck. She had some herniated discs in her neck. They were causing neck pain, arm symptoms of pain, weakness. She saw some neurosurgeons at the hospital. They told her she needed to have a fusion. She didn't want to have a fusion, so she started to look around for alternatives to fusion. Of course, they didn't have any alternatives. All they know how to do is fusion. So she searched on the internet and she found artificial disc surgery, but she didn't want something stuck in her neck made out of metal and plastic. And she wasn't happy with the success rate of artificial disc surgery. It's not that good. She wasn't happy with the complication rate of artificial disc surgery because it's high. So she kept searching and she came across the Deuk Spine Institute and the Deuk Laser Disc Repair. And we actually did laser surgery on the 2 herniated discs over a year and a half ago. And she's doing fantastic with her neck. And now she's having back problems, and of course she came right back to the Deuk Spine Institute, and here in Florida she flew here yesterday. We saw her in clinic. I reviewed her MRI with her over the internet using Skype, and I felt that she was a very good candidate for the Deuk Laser Disc Repair. So she came out and here she is having surgery, having her back fixed. Now, a lot of people put off surgery because they don't know that surgery is going to work. They're afraid of surgery. They're afraid of the risk of surgery, the risk of dying or bleeding or infection. The good news is the Deuk Laser Disc Repair has never had a complication in our surgery. We've never had anybody die or paralyzed or bleeding to death or infection. It's a very safe surgery. So she chose to have this surgery done rather than an open back surgery like a fusion. Yes, you have a question.
Yes, we do. One of our viewers on Periscope is wondering, in the disc, which does not regenerate, does it close itself after the surgery is done?
And I heard something about a disc and regenerate, does it close itself after the surgery is done? But I didn't catch the very beginning.
I believe they are referring to the annular tear. They're asking if it closes itself after the surgery is finished.
Yeah, great question. So one of our viewers is saying, Dr. Deukmedjian, after you're done here, will the annular tear heal itself? Will it close over? The answer is yes. That is exactly what's going to happen. Once I clean out this blue stuff, the herniated disc, the annular tear will finally, after years, be able to seal over and close. That's what it's been trying to do. It's been trying to do that for years. So how many of you have an automatic garage door opener? Most people do, right? You click a button, the garage door opens. You click a button again, it closes. But what happens if your kids leave a skateboard or a bicycle under the garage door? You go to close it, and it tries to close, but it can't close because the bicycle is in the way. So it just opens again, and you click a clicker again, and it just keeps going down and hitting the bicycle, and then opening again. So you can never get the garage door closed as long as the bicycle or skateboard is in the way. Well, this is the same thing. This disc annular tear in everybody with a herniated disc, everybody, they have an annular tear, and the annular tear is trying to close and heal itself, but it can't because this blue stuff is in the way. It's blocking the healing. So the disc just keeps trying to heal and trying to heal and trying to heal 24 hours a day, 7 days a week. And when you get up and lift things or bend or twist, it just pushes against that inflammation that's going on, the healing inflammation. And it just sets it off and causes pain. Because inflammation is painful. And the pain that people get from a herniated disc is from inflammation inside the annular tear. Again, this is my discovery, my contribution to medicine. I figured it out. Everyone else seems to think the pain comes from bone slipping or scoliosis, or it's not true though. The scoliosis, the spondylolisthesis, they don't cause pain. Okay, what causes pain is this tear. Now the next level we're going to treat, this is L3-4. The next level we're going to treat is L4-5. L4-5 has spondylolisthesis. And you're going to see that spondylolisthesis on the x-ray. We're not going to fix the spondylolisthesis, but I guarantee you her back pain will be gone. Her back pain will be gone because we fixed the cause of the back pain, which is not the spondylolisthesis. But if you ask spine surgeons, oh, she has back pain, she has spondylolisthesis, what's causing her back pain? They'll tell you it's a spondylolisthesis, but it's not. They're wrong. They just don't know. They don't know the truth because they haven't been trained properly. New discoveries are made in medicine every day around the world. Those discoveries, when they're good, they're vetted scientifically through a process called peer review and publication. If you find something significant in medicine and healthcare as a new discovery, you're going to want to publish that discovery. And that's exactly what we did with the Deuk Laser Disc Repair and the annular tear. We published it. I published it in 2012 and 2013. A group of neurosurgeons reviewed my work, and it was approved after, of course, a lot of consternation because they'd never seen anything like this before. And many of them thought I was just nuts. And if I relied on their what would you call it, their approval to do what I do, we would never make any progress. Think about it. Discoveries are made usually by individuals or small groups of individuals, and those groups don't represent the entire body of people that are involved. So there are 1 million doctors in the United States, but only one of them discovered, for example, arthroscopic surgery for the knee. One doctor was creative and figured it out, presented it, but remember, in the very beginning, it was only one doctor that knew about it. The other 999,999 doctors had no clue what arthroscopic knee surgery was. So discoveries in medicine, progress in medicine usually happens at a very small level in a very focused area. Same thing with stem cells, right? I didn't discover using stem cells to fix pain, but now we do stem cell therapy here at Deuk Spine Institute. We didn't create it, we didn't pioneer it, but we're what's called an early adapter or adopter. We adopted the technology early, and we've been providing it to our patients for years. Okay, so new discoveries eventually work their way out to the rest of the world. And what you're seeing here with this Deuk Laser Disc Repair is a new discovery that I discovered, and we're trying to get the word out to the rest of the world. This is a better way to fix back pain than fusion. All right, we're just about done with this disc. It will seal over as long as she doesn't re-injure it. It will heal itself in time. Let's see what we've got here. Yep, there's medial. There's the end plate. That stuff right there is just loose connective tissue. There's some fat up there, some veins, and then there's going to be, oh yeah, the nerve is on this side. So her nerve is buried in that fat right there, the yellow stuff. It's very common to have fat around your nerve. Laser off. It's very common. Everybody has fat around their nerve. We've talked about this before. Why would there be fat around the nerve? Energy. Fat is a storage form of energy. Fat is probably the most efficient storage form of energy in the human body or any animal body. Why? Because it doesn't need water. That's right. Dr. Santiago knows his physiology. Good. So you can pack energy densely into fat. Very dense. As a matter of fact, fat has the highest energy content per gram, much higher than carbohydrates or protein. So fat is the most concentrated form of energy in the mammalian body, and we have fat throughout our body. I'm going to need to stand here. Thanks. Including around your nerve roots, because the nervous system has, of all tissues in the human body, it's the most metabolically active tissue, meaning it requires the most amount of energy per gram of tissue. Now, some people who don't use their brains very much, they don't need a lot of energy, right? I hope everyone uses their brain. All right. So, does the brain use fat for energy? Does anybody know the answer to that? The answer is no. The brain does not use fat, ever. The brain uses only sugar, only glucose. It is the only energy form shot the brain will use. So the fat that we store in our bodies can never be used by the brain. Shot. I think the brain is the only tissue that discriminates, right? I think all other tissues can use glucose and ketone bodies, which are derived from fat. Okie doke. We are going to be doing L45 next. I've just placed the guide wire. I'm going to put the dilator over, and we're going to go through the same little hole in her back, in her skin. We have a tiny little cut. 7 millimeters, and we're gonna just pass down this guide wire. Remember, the end of this metal thing, this dilator, is tapered, so it literally spreads apart tissue. Shot. And I can just push it down the guide wire because I already know the path is safe. So it looks a little scary, but it's kind of like using a paved road at night. You know, the road is safe. It's not going to drop you over a cliff. Now, sometimes you get little animals on the road, or somebody leaves a car parked on the road. Fortunately, we don't have that same issue here, but once you have a pathway that's safe, you could use it to get down to the disc to fix it. All right, so we're making progress. Again, I'm watching my guide wire. I don't want it moving into the pelvis. Shot. I'm passing through the tear now. I can feel a change in the resistance. I'm looking at my angle right here. I'm studying it and I'm happy with it. Shot. So I can feel it going through. I can feel this dilator tip going through the tear. And you can see on the x-ray it's perfect. Now I'm going to bring this tube down. Can you all see the tube? Maybe hard to see.
Yes, we can.
So I'm going to do her entire surgery through this tube. And let's say these are the 3 discs I'm operating on. Okay? 1, 2, 3. Just like that. I'm going to put this tube in, do the first disc, take the tube out, reposition, and go in through the same entry point but a different target, which is the second disc. Fix that one, come out, and then re-aim for the third one. So I use the same entry point in the skin, but I can hit 3 different targets. Okay, beautiful, huh? All through one tiny little incision. Who wouldn't want this surgery? Why would you ever want a more invasive, more destructive surgery on your spine? You shouldn't. Only misinformed people would want something like that. Well, we've created an archive now of almost over 1,000 videos that are available on YouTube, Facebook, of surgeries done here at Deuk Spine Institute over the last 6 years, and testimonials of patients who have had surgeries done with their back being cured or their neck being cured. Maybe a little bit more. So there's a lot of video content out there available that you could learn from. We also have our Deuk Spine Institute app, which is free. You can download it on your computer or phone, and you can learn a lot about different back conditions. For those of you who've never been to Deuk Spine Institute, we actually use the app for all of our patients as they come into the clinic and they're seen and we make diagnosis. We actually put their diagnosis on the app. And that way when they leave, they can revisit at any time their diagnosis. And the treatment that we recommend is also on the app. So it's a very, it's a tool that we created at Deuk Spine Institute that is our brainchild, and it's available nowhere else in the world. The use of the app to put the patient's diagnosis and treatment plan both that they can refer to. Everything okay?
Yeah, I just lost the EKG, but I have felt some sicknesses.
Do I need to stop?
No, you don't.
All right, so we're fixing disc number 2.
Anything up there?
You need help? All right, let's get the laser in. We've had some really good questions from our audience. If you're watching this surgery today on the 18th of June, 2020, you're most likely watching a live surgery. And the reason we stream live is several reasons. Number one, it gives me a chance to answer questions the audience may have in real time. So if you're watching this video and you're thinking, wow, what's that? Why are you doing that? Just ask the question. I'll answer it for you. Also, we want you to see what happens with these surgeries. There are very few surgeons in the world that will ever show you how they do their surgery. As a matter of fact, I don't know of too many that will show you their spine surgery, the whole spine surgery. They all want to show you little pieces. They edit it. Their surgeries are heavily edited because they're cutting out the parts they don't want you to see. But I'm a big believer in honesty and truthfulness and transparency. And I think that doctors have an obligation to be honest with their patients and to, to tell them all the potential risks, benefits that are potential, and to really show the patients as much as they can, educate the patient as much as they can about the facts, so patients can make an informed decision about their care. It's very important. I mean, sometimes we lose sight of the fact as doctors that it's not our body we're treating, it's someone else's. And, we get so ingrained in our head that there's a specific treatment that has to be done for a specific diagnosis. The reality is that there's usually more than one treatment that are available. And ultimately, it's the patient's choice as to what they want to do for their body. And what I found is that different people will choose different choices depending on, their understanding about the disease and the condition they have and the treatment available. Also, they may choose based on their finances, what money they have available to pay for what things. They may choose also based on the help they have available at home after the surgery. Do they have enough help to take care of them? How long will that help be available? So there are many factors that people take into consideration when choosing their treatment, but in my opinion, the choice should always be the patient's choice. As long as you present the patient with reasonable options for treatment, let the patient decide what they want done. So to that end, I believe in broadcasting live surgery and live treatment so people can see what they would be getting themselves into. Honestly, the other reason I broadcast these surgeries is because I know just how good they are compared to the alternatives. So I'm confident that anyone paying attention with half a brain will be able to see that this surgery is 1,000 times better than open back surgeries. Don't disappoint me now that I said that, okay? So, since there are no questions, I'll just keep babbling. Sometimes people think, Dr. Deukmedjian, you do these surgeries because that's all you know how to do. No. In my career of 22 years of spine surgery, neurosurgery, I've done well over 1,000 spinal fusions in the back and over 1,000 spinal fusions in the front of the neck, ACDF, and over 500 posterior cervical in the back of the neck fusions with laminectomy. These are the big complex spine cases that, there's two types of spine surgery. There's simple types of spine surgery like microdiscectomy, laminectomy, and then some of these little inner body devices they put in, interspinous devices. These are simple surgeries, kyphoplasty, spinal cord stimulator, maybe a morphine pump. These are very simple surgeries. This is what the most spine surgeons know how to do. Then there's complex spine surgery, which is reconstruction, decompression, instrumentation, fusion, complex spine surgery. I've done the most complex of the complex spine surgeries. I've done hundreds and hundreds of cases. But why do I choose to do this simple endoscopic surgery? because it's better for the patient, not better for me, better for the patient. It's a faster recovery, it's a safer surgery, and it works better than any kind of open surgery, whether it's a simple open surgery like a microdiscectomy, laminectomy, or a complex spine surgery. There's no better result than this surgery you're watching right now for fixing a herniated disc or spinal stenosis. None of the other surgeries in the world have a better result than this surgery you're watching right now. 95% relief on average of pain. There's no surgery in the world that gives you that for back pain or neck pain. Half of the patients get 100% relief. So when you ask me, or you wonder, Dr. Deuk, can you only do endoscopic surgery? Absolutely not. I can do all spine surgery, no matter what it is. And that's why I talked about my training last surgery, because, you know, not every spine surgeon can do all the spine surgery. Sorry. Let me just pull this back a little bit. Very few spine surgeons are capable of doing all spine surgery. Out of all the spine surgeons in the world, probably less than 5% can do all spine surgeries. But to be honest with you, doing spine surgery and doing it well is quite easy. And anyone can do it, but they have to be trained properly. And that's where the failure of our system is, in training. The reason our system has failed is because there's no uniformity in training. There's no uniformity in training. The reason there's no uniformity is because every training program has 3 or 4 or 5 faculty, and every one of them does the surgery differently. So if you look at the training programs in neurosurgery, there's 120 training programs. Each training program has an average of 5 faculty. What's 120 times 5? 600, right? There are 600 different ways of doing the same surgery right there, because each faculty member does the surgery different. I guarantee you. Even if it's brain surgery, it's done different. Doesn't just mean spine surgery is done different. I'll give you an example. When I was a resident, I was a senior level resident, and there was a 1 week in my residency as a senior where we had 3 patients come in with 3 different doctors, 3 different neurosurgeon faculty. Okay? They all had exactly the same diagnosis, exactly the same. It was a brain tumor, and the tumor was located just inside where the ear is. It's called an acoustic neuroma. It's a very complex tumor to remove. It's very difficult surgery. And the first doctor I did the surgery with, Dr. Roper, took 18 hours to take this 6 by 6 centimeter tumor out. 6 centimeter by 6 centimeter by 4 centimeter tumor. And of course he didn't get all of it out. He got 90% of it. But the piece that he left because he wanted to preserve some neurological function. But he left a little nubbin, and then we were going to radiate that later if it needed to be. The very next day I did exactly the same surgery, no different. But I did it with Dr. Stephen Lewis, another faculty neurosurgeon, an expert in tumors and vascular surgery, just like Dr. Roper was. But with Dr. Lewis, instead of 18 hours, it literally took 10 hours to do the surgery. 10 hours. Then the next day, I operated with Dr. Friedman, the chairman of the neurosurgery program. This is after Dr. Roten had retired. Dr. Roten was the world expert at removing these tumors, but Dr. Friedman had taken over his position as chairman. Dr. Friedman is the fastest neurosurgeon I know, besides myself. Dr. Friedman had that tumor out in 5 hours. So, all experienced neurosurgeons, all world-renowned experts, same exact tumor, same exact type of patient, same exact result in this case, and they all did the surgery differently. One took 18 hours, one took 10, one took 5. Okay? That just goes to show you there's no standardization. Now, as far as the steps that were taken, they were similar, but there were huge differences. And if you watch those 3 surgeries yourself, you would see that there were differences in the way they did the surgery. One would do things one way, the other would do things differently. And the end result would be different as well. How much temporal bone they took off, how much tumor they took off. We just lost our endoscopic feed. Yep, we kind of need to keep the plugs in the wall. Is that the best plug? Is that the best location?
Pull the entire cable out. There you go. Be careful. Slowly.
Did you guys lose your visual feed?
Yes, we did.
Yeah, we lost it too. We just accidentally unplugged the scope. So we're getting it back up and running.
Standby mode, please. Jordan.
Turn the light on, please.
Light on. Power. Power. Standby. That's good, Jordan. That's good.
Okie dokie. Are you able to see now? Sorry about that.
Yes, we can.
I got worried for a second. I thought maybe we didn't pay our electric bill. Just kidding. So anyway, getting back to the topic at hand, I'm just telling everyone that if you think all surgeons are the same, all neurosurgeons are the same, all spine surgeons are the same, they're not. And I don't mean they're just different from a personality standpoint. I mean they're different from an operative standpoint, from a decision-making standpoint, from a diagnostic standpoint. Dramatic differences. You understand? And we see these differences every day. Whether you hire a lawyer to take your case, some lawyers are a lot better than others. Some of them just suck. Most of them suck. Whether you hire a termite person, whether you take your car in to get it repaired, you know, if you have a faulty engine, you take it to different places, you're going to get different service, different costs, different results. So really, when it comes to spine, where do you go to get the best? Well, I believe you go to Deuk Spine Institute. You're going to get the very best care, you're going to get the best results, and honestly, the least expensive. So the least cost, the fastest recovery, the most successful procedure. So, show me anyone else who's broadcasting their spine surgeries live. Yep. Yeah. She wants to go home. No, not yet. I'm not ready. No. So the first patient, before I came in here, if you watch the first laser surgery, she was crying when I saw her earlier. She was crying because her leg pain is gone that she had for years. She was crying because her back pain is gone. We cured it with the surgery. But she was a little bit nauseated. So we're keeping her just to make sure she's okay. All right, we're done with this disc. Maybe just a little bit lateral here. We have one more to go, and we will be done for the day. Does Dr. Patel have any more cases today, or is he done? Luis? He's done?
Unless he had something else.
Okay. All right, folks, take a look at 12 o'clock. You got fat coming in there, some veins. I just want to hit this stuff up. I'm not trying to get rid of the fat, just so you know. But I am concerned a little bit about this right here. It looks like some scar. Actually, it looks like scar and bone spur. This is a bone spur here. So I'm just going to zap it away. Just to be completely thorough. Remember, this patient's traveled from Chicago to Florida to have her surgery done. I don't want her going back and having any problems. I want her to be very, very happy and safe. And so if I leave something here, if I get impatient and I don't fix everything that needs to be fixed, well, She may still have pain. She may want to come back, and that's a big inconvenience for her. I don't want to put her through that. I want her to be leaving Deuk Spine Institute satisfied. Kind of like how you used to leave Disneyland satisfied years and years ago. Nowadays, anytime I leave Disneyland, I always feel dissatisfied. Anybody else feel that way? Disney World, huh?
I even try not to go. 'Cause it's
You know why I'm dissatisfied? I'm dissatisfied because if you go to Disney or you go to Universal, I want to go for the rides, right? But nowadays I find myself going and just eating food.
Lights on, please.
Because the lines are too long. You know, and so you go to an amusement park to go on the rides, but the lines are too long. So all you end up doing is eating their $20 burgers. And that's terrible. I could stay home and eat a hamburger for a lot less. All right, I need the grabber or the dilator, actually.
I feel bad. Especially a young girl, I don't even take her there.
You don't take your daughter there? Why not? Same reason?
It's too frustrating.
You can't get on the rides. Yeah, huge crowds. You can't get on the rides. It's very frustrating. I agree.
You know, you can probably start it really nice, but then once it gets, mid-morning,
Yeah.
I like to be there like first one in line, early.
So,
Then by the mid-morning, it's all crowded.
yeah. Same thing with the Kennedy Space Center, right? You may show up for a launch and then they scrub it because of the weather. And it's dissatisfying. So, we want to be the one business that people come to in the Space Coast that they leave satisfied. That's my goal. Kennedy Space Center may disappoint them. Universal Studios may disappoint them. Disney World may disappoint them. But Deuk Spine Institute won't disappoint. Right, Luis? I got to tell you, I got a great team here. Best nurses, best staff, best doctors. All right, last one. Let's get an x-ray and see what we got. Woo! It looks like Gumby. Anybody know who Gumby is? Anybody? Yeah, you don't know who Gumby is? Right, right. Oh no, Mr. Bill. Gumby and Pokey. Sad, really sad. Look it up when you get done. Just not on the clock. Just kidding. Right, these youngers, they don't know who Gumby is. Shot? When we were kids, the older ones of us growing up. Cam, do you know who Gumby is? Yeah. I used to have a Gumby when I was a kid. That was like my favorite toy. You can bend his arms and legs. People know what slinkies are because somebody reintroduced the slinkies. People know what Rubik's Cubes are because they reintroduced the Rubik's Cube. But nobody has reintroduced Gumby. Maybe I'll create a Deuk Spine Institute Gumby and hand it to our patients.
I'm blue.
I think they'd like that, huh?
Yeah, and it's gonna be blue.
It's going to be a blue Gumby. We'll rebrand Gumby. You like that? Rebranding Gumby? This is what happens when you don't ask questions, by the way. We start talking about weird things. All right, she's got some scoliosis or something there, but we're way twisted. So maybe bring your side down a little bit. Let's see if we can get a better picture. Shot? I don't know, I think it's worse. Try the other way. Yeah, that's probably the best we're going to get. So clearly I have some distance to travel before we get to the disc. Let me have the mallet and the impactor. So we're done with 2 out of the 3 discs. We only have 1 more to go. Of course, we have the hardest one to go. Shot. Shot. That looks pretty good. Anybody see the movie Revenge? Anybody? Revenge of the Nerds. We're not, no. No. It's a newer movie. It came out a couple of years ago. It's called Revenge. It's a good movie. Just thought I'd mention it. If you like drama. It's definitely not appropriate for kids. All right, let's see what we got here. That looks good. I'm going to take this out. Give me the mallet. No, come on. Shot. All right. Good. It went in nicely. She's clearly relaxed. Thank you. This is our last disc. We'll be done with this. And we'll be done with our surgery. And we'll get her to recovery. Hopefully Dr. Patel's procedures didn't cause too much discomfort for her. Right? But if she has any, it's definitely Dr. Patel's procedures. I heard the NBA is going to be bringing all their games to Orlando. Yeah. Is that true? That's what I heard. Over to Epcot? Yeah, the ESPN over there. My daughter did all of her dance performances there. All the national, international. It's an amazing facility. Have you seen it? I have. Shot? All right, so I'm advancing the dilator at this point, which I don't want to do. So I need to pull that back a little bit, keep that available. Mm-hmm. Shot, let's see where we are. I think we're pretty good. I think I'm just going to leave it where it is, and I think we're good. Shot. You know, there's really very few good movies out nowadays that I've had to start going back and watching the old ones. I was watching Silence of the Lambs the other day. You ever see that one? I like the first one. Then it starts getting weird after that. You know, some crazy stuff, but I thought the first one was pretty good. I've been watching all the old dramas, you know? The old mystery dramas. From like the early 2000s. All right, last disc. It's crazy to think that my children may not know who Spielberg is. You know? You grow up with Spielberg's movies, they're the best movies. Some of the best movies ever made. And yet, they're going to be buried in time. Because all these digital companies, you know, that sell movies now, they sell them online. Like Apple Movies, Netflix, Amazon Prime. They all want you to watch the newest movies. That's how they make money. So they're always promoting the newest movies. So the old movies are finding harder and harder to find them, and the only way you can find them is if you look for them specifically. You know what I mean? Now sometimes they do promote the older movies, but it's getting harder and harder to find them.
We have a question.
Yes.
One of our viewers, Todd, who submitted this question to the Duke Spine Institute app, asks, what's the difference between DLDR and microdiscectomy?
All right. Good question. Thank you. So one of our viewers is asking, what's the difference between Deuk Laser Disc Repair and microdiscectomy? Let me just stop for a second. Why am I seeing so little water? Fluid. Are we checking the pressure? Getting a lot of bubbles and a lot of debris. Yeah. You guys got to pay attention to that. All right. So the answer has about 100 different points. But I'm going to focus on the 10 most important differences. Okay? And I'm going to talk about the most important differences first. So the most important difference between the Deuk Laser Disc Repair and a microdiscectomy, both surgeries are done for herniated discs. A microdiscectomy is only done to get rid of leg pain from a herniated disc. Deuk Laser Disc Repair is done to get rid of leg pain or back pain from a herniated disc. A microdiscectomy cannot get rid of back pain. It can only get rid of leg symptoms. So if you have back pain and sciatica, you're going to want the Deuk Laser Disc Repair because the microdiscectomy does not fix the annular tear. Okay, why are we getting... Is there good flow? No, our irrigation is barely coming out. Why is that?
Can you check the pressure, please? What's going on?
The pressure, maybe the tubing is not good.
There's something. We're being...
It's not pinch anywhere over there?
Oh, it just got better. I don't know what happened. What'd you guys do? You pulled on it? All right. Well, whatever pulling you did, you made it better. Still a little bit hazy. Not sure why we're so hazy. All right, sorry about that. Getting back to the question. Microdiscectomy is a surgery only done to fix pain shooting down your leg called sciatica. Deuk Laser Disc Repair fixes sciatica. Microdiscectomy does not cure back pain because it doesn't fix the annular tear that led to the herniation. Deuk Laser Disc Repair is the only surgery in the world that fixes the annular tear along with removing the herniation. So it fixes the back pain and the leg pain. If you go to a spine surgeon with a herniated disc and say, will your microdiscectomy take away my back pain? They will tell you no, because it doesn't. Now, if you want to get rid of back pain, you have to do a fusion. Aside from the Deuk Laser Disc Repair, a fusion. Artificial discs work too sometimes, but they don't work that well. So there's your biggest difference, getting rid of back pain. Microdiscectomy doesn't, Deuk Laser Disc Repair does. The next big difference is microdiscectomy is done with a cut in the middle of the back. And the surgeon goes down and then gets to this bone called the lamina and another bone called the facet. It's a facet joint. And the surgeon must go through that bone to get to the herniation in a microdiscectomy. So to go through the bone, they have to take it out. They're taking bone out of your spine to create a pathway to get down to the herniation and fix it. Removing the bone is completely unnecessary if you go through the natural hole that's already in the spine. And that's what we're doing. But you got to come from the side. You can't come from the straight back. So the technique I'm using with Deuk Laser Disc Repair goes through a natural hole that's already there. So we don't remove any bone from the spine at all. Whereas a microdiscectomy takes a hole in the lamina called a laminotomy and then it takes bone out of the facet joint, F-A-C-E-T joint, and the facet joint's what holds your spine together. So by removing part of your facet joint, they're weakening your spine. Then your spine's going to start wobbling around, and you're going to get another herniation, and you're going to get more pain in your back, and you're going to need a fusion. So a microdiscectomy leads to the need for more surgery in the future. But a microdiscectomy is what every spine surgeon in the world is taught to do. So they all know how to do microdiscectomies in their training, but microdiscectomies are dangerous, unnecessary treatment. And the only reason those surgeons do it is because they don't know how to do the Deuk Laser Disc Repair. The Deuk Laser Disc Repair takes sophisticated training and equipment that they don't have access to yet. Someday they will. So microdiscectomy removes bone out of your spine. It destabilizes the spine and increases the likelihood of more surgery on your back at the same place. Whereas Deuk Laser Disc Repair goes through a natural hole that's already there. It doesn't remove any bone. The only thing that Deuk Laser Disc Repair does is make a cut in your skin. That's the only damage done from the Deuk Laser Disc Repair, is a cut in the skin. And that cut is 7 millimeters. 7 millimeters. A microdiscectomy is a 21 millimeter incision. 21. That's 3 times the length of the Deuk Laser Disc Repair scar in your skin. So microdiscectomy has a much bigger scar in the skin. It has bone removal, which weakens and destabilizes your spine, and you're going to need more surgery in the future because of that. And it doesn't treat back pain. Only treats leg pain. Microdiscectomy is a bloodier surgery. You're going to lose a lot more blood with a microdiscectomy because you're actually making a bigger incision and you're going through muscles to get there. You literally have to peel the muscles off the spine or cut the muscles out. So there's muscle damage with a microdiscectomy. There's no muscle damage with the Deuk Laser Disc Repair. We're not damaging the muscle at all. Microdiscectomy is a much more painful surgery to recover from for the patient. It's a much longer recovery. Deuk Laser Disc Repair is a 1-hour recovery. Microdiscectomy, you're going to be recovering for weeks and months. Microdiscectomy requires the use of narcotic painkillers, opioids, after surgery. Deuk Laser Disc Repair does not. You use basically an anti-inflammatory or Tylenol for pain. So microdiscectomies require powerful, dangerous painkillers called opioids, whereas Deuk Laser Disc Repair does not. Microdiscectomies have a higher complication rate. The complications that happen with microdiscectomies include nerve damage, spinal fluid leaks, infections, and injury to blood vessels. Deuk Laser Disc Repair, we have none of those complications, 0. So your complication rate is much less, 0 with Deuk Laser Disc Repair if it's done right. Now that's if I do it. You know, if somebody else out there tries to do my Deuk Laser Disc Repair on a patient, unless they're trained properly, they're going to end up having complications. And that's not my fault, or it's not the procedure's fault, because some surgeon is doing things they shouldn't be doing. I think that's a pretty good list of differences between microdiscectomy, and worldwide there's probably 500,000 to 1 million microdiscectomies done around the world every year. Say 1 million. Every single one of those microdiscectomies could be not done, and in place of them the Deuk Laser Disc Repair. And the patients would be happier, the results would be better, and the cost is going to be about the same. You know? The cost for the surgery is about the same. The cost of complications is much higher for microdiscectomy because Deuk Laser Disc Repair doesn't have complications. So complications cost money. If you have to be readmitted to the hospital after your surgery, after your microdiscectomy because you have an infection, you're going to have antibiotics. You're going to have to stay out of work for 6 weeks probably. you're going to have to be, you know, getting treated with additional treatment that costs money and time and suffering. So there is absolutely no circumstance in the world, in my opinion, where microdiscectomy is better than Deuk Laser Disc Repair. None. All right, we're just about done. I need 5 minutes or less. I'm at the back of the disc right here. I got a little bit of epidural vein bleeding. Patient is responding because she's basically coming out of anesthesia. You're doing fine. Everything's okay. Just lay still. But this is going to be a painful area of the disc. Just need a slight tinge of propofol. She okay?
Yeah, she's fine.
Want me to stop or you?
I have the propofol in the same line as the blood pressure cuff, so when they get mine
Yeah, I understand.
wrong, it kills them.
Yeah, that's fine. Yeah, I just happen to be at the outside of the disc where the most nerve fibers are, where the greatest amount of nerve fibers. All right, are we ready, folks, to finish this case up? Everybody ready? Will you, Sean, will you do me a favor and let's do a quick video of our patient being discharged if she's willing to. Will you, let's go ahead and take any other questions people have on this case right now, and then I'll wrap this up. We'll stop the stream and we'll go ahead and do a video of our first patient as she's leaving our facility. We'll do a quick testimonial. Any questions from
There
our
are none
audience?
currently.
I'm sorry?
There are none currently.
All right, so why don't we, folks, we're pretty much done here. I'm going to have Sean stop the live stream and go and we'll set up for doing a video on the patient who already had surgery, and we'll get that posted. I am just about done. You want to show the incision first, Sean?
Sure, that'll be fine.
All right, laser off. We're done, folks. We've done everything we can to repair the tear, remove the herniation. I think our patient will do great. Scope off. I'll show you the incision. Here you go, fluid adapter. All right, are you ready, Sean?
Yes, we can see.
All right, so I'm just going to apply pressure for a second. Mike, this is the patient's back. This black line is the middle of the back. So what you're not seeing is the other side, but this is kind of the whole back right here, middle. Microdiscectomies, the incisions are done here. So to fix 3 discs, for example, in this patient, we'd have to make a really long incision. We'd have to be removing a lot of bone. By removing the bone to do a microdiscectomy, it actually weakens the spine even more. She's already got scoliosis and listhesis and kyphosis, so her spine is already shifting out of place. It's already wobbly. So by removing the bone, it's going to make it even worse. She's definitely going to need a fusion. So there's no microdiscectomy option for this patient. All right, there's the incision. Look at that, folks. The entire surgery, 3 discs, curing back pain, curing leg pain, all done with a 7mm incision for 3 discs. There's no other surgery in the world that good. All right, let's go ahead and end the stream, and we'll go do our video of our post-op. Nice work, everyone. As usual, Dr. Santiago.